Good afternoon. At the outset, I'd like to thank the AOS for giving us this opportunity for this IC and Dr. Suma Ganesh for including me in this talk. So I'll be talking on etiology and pathogenesis. As Madam has told, it includes all visual dysfunctions caused by damage to or malfunctioning of the retrochiasmatic visual pathways in the absence of damage to the anterior visual pathways or any major ocular disease. So the vision loss can range from mild visual impairment to complete visual deprivation. So I have divided this into this thing based on the time of the insult or based on the area of the damage. So based on the time of the insult, it can happen from intrauterine to anywhere up to adulthood. So in early onset, it can be developmental anomalies, which I have divided into defective closure or in defective clefting or migrational anomalies or perinatal insult, or in the late onset, it can be circulatory arrest or other infections. So I'll be going through each one. So we all know that the embryogenesis, in the first month of the embryogenesis, the whole development of neural tube and neural tube closure, everything happens, invagination, and then neural tube closure happens. So you can have, in the defective closure, you can have cephalocele, or defective cleavage, you can have hollow prosencephaly, or defective neuronal migration, we have these defects. So coming to cephalocele, it is nothing but extravagination, of the intracranial contents into the dura or into the skull. It is not inside, so it is outside. So you can have all these defects. It can be occipital lobe, where you can have no block syndrome. Even yesterday somebody was presenting in the session, no block syndrome. So it will have other associated anomalies. So whenever we see any high myopia or VR abnormalities and all those things, we should think of neuroimaging and finding out if there is any other encephalocele is there. Frontoethmoidal is quite common in our country. I mean, in Asia, you can have an associated ipsilateral optic nerve dysplasia. Or nasopharyngeal encephaloceles are not uncommon. They are the main problem is it is because of the stretching of the optic chiasma. So once again, you will not see anything obvious when you see put a torchlight or see the fundus examination. Everything may be normal in these cases. So it can be defective cleavage also, which happens in the second month of embryogenesis, and you can have the various abnormalities associated. The main problem being the signaling protein, which is abnormal. So yeah, you can have a Patau or Edwards. All these things can also be a part of the developmental anomalies. Or the neurons, usually they start migrating in the embryogenesis. So they migrate from the ventricular and the subventricular zones, and it starts around 2nd to 4th month, and then it reaches the cortical plate. So anywhere, if there is a problem, you can have this. If it is in the embryonal stage, you can have lysencephaly, where they stop in the intermediate zone itself. As you can see here, it will be a very smooth brain. There will be absence of cortical gyri. Whereas in pachygyria, you will have the migration stops at a later stage, you will have a reduced number of gyri. Whereas in polymicrogyria, you can have a multiple abnormal gyri, smaller in size. Or if it happens in the fetal stage, as you can see here, there is a complete dissolution of the parenchymal sac, and so you can have the absence of this intracranial contents. So anywhere this thing happens, you can still have all this. The main problem which we face here, as the previous speaker Sasikala was also telling, we are having this problem, periventricular leukomalacia, which is nothing but there is a hypoxic insult to the brain. So our country is now going through a change, like what we were the early ROP, this thing is happening. Now we are also in the Western countries, they are seeing more of CVI as the main cause of blindness, but it is not, we are also not far behind, because our preterm care is also improved very much, and so we are now showing ROP growth also and CVI growth also. So as you can see here, there is a cerebral vascular autoregulation is absent in these preterm infants or early term infants or low birth weight babies. So when they have an ischemic injury, they can damage the pre-myelinating oligodendrocytes, and this can lead on to diffuse gliosis or periventricular necrosis. And as you all aware, it is mostly around the lateral ventricles, and the corticospinal tracts also go close to the ventricles. So whenever this damage occurs, there is the added disadvantage of the child having a spasticity or diplegia or all the other motor anomalies, because the corticospinal tract gets affected. And as such, all the other systems, so it is not a single just cerebral visual impairment, as you know, it's a full term. So other anomalies are there and multiple disabilities are there in these children. And we should remember that the watershed zone. What is the watershed zone? It is the commonest area where you can have a problem, because it is more prone for ischemia and loss of the neurons. It is the zone between the anterior and the middle cerebral and the middle and the posterior cerebral, and the occipital lobe is highly at risk to all this hypoxia, because it needs the highest amount of glucose as well as the oxygen flow. So any ischemia in the white matter, it will result in the death of the brain cells, and especially the occipital lobe. And these are the various pathways where it can get affected. Like you can see the field defect, inferior field defect, you will get when it is a posterior superior periventricular affection, or you can have a generalized depression of the field, as you see here, or when the optic radiation is involved, or increased cupping. So as you can see here, Dr. R.K. sir keeps telling, Dr. Ramakrishnan sir, any cup, very pallor is more than the cup, then it is not a glaucoma. Most probably it is some other cause. So always just don't see the cupping alone, you see the disc pallor is there or not there. If the pallor is more, then we should see for other causes. Or you can have impaired visual memory. In the premature infants, the other main problem is, other than hypoxia, is the periventricular and the intraventricular hemorrhages, and where you can have the bleeding within 48 hours. If it happens, it can lead on to either hydrocephalus, once again, which can compress the brain structures. Either it can be, even if you do a VP shunt, sudden decompression can cause the CVI, or long-term shunt misfunction. So the problem with hydrocephalus is, even if you put the shunt, we should keep them on long-term follow-up, and sometimes papilledema will not be seen even though the shunt is not functioning. So we should keep this in mind, and these are the three factors how the bleeding can cause the damage. Like it can be a hydrocephalus or infarction or a porencephalic cyst. The other in-term infants, what we have is, once again, the cerebral autoregulation is affected, or it can be a perinatal infections, like all these meningitis and all that can cause the problem. In the older children, it is either circulatory arrest, where the basal ganglia can also be involved. The other causes, previously they used to have meningitis as a very common cause for CVI, this thing, and H influenza was the most common cause. And the main pathophysiology is because of the thrombophlebitis and arterial occlusion. And the second most common cause was hydrocephalus. These days it is much more under, we don't get so many cases of hydrocephalus or this thing, but still we do get meningitis or ADEM, we do see these cases. And here it is possibly because of the HIE, because of the compression of the posterior cerebral arteries in hydrocephalus. And we should not forget that trauma can also cause, and battered baby syndrome. Western countries is much more common, but I think in the coming years we may also see some changes happening, because of our culture is also sometimes changing. So the other causes is hypoglycemia, hemodialysis, seizures. Infantile seizures is one important cause which we should remember. And nowadays hypoglycemia is quite common. Nowadays pediatricians or neonatologists are routinely doing the blood sugar after delivery, and they are maintaining the sugar levels, because we do see a lot of cases which is missed, and only if you get the history out, we will get this. So based on the area of the damage, I won't go into the details. There are mainly two pathways other than the just occipital cortex, and this is the tree of vision. I think the next speakers will be talking in detail. So these are the four areas we should based on the area of damage. It can be the dorsal stream, or the ventral stream and the temporal lobe, or the middle temporal lobe, or the visual occipital lobe. So when the occipital lobe is involved, which has the maximum highest blood flow, you can have all this impaired visual fields, visual acuity, contrast sensitivity, and the stereopsis. And when you have the middle temporal lobe, which is involved, you have the akinetopsia, absolute or relative. That is, they won't be able to see when the object is still, but when it is moving, they can pick it up. And when it is the ventral stream, that is the Watt pathway, and when you have the ventral stream that is involved, it impairs your conscious vision. And the visual recognition and memory, so faces, prosopagnosia or topographic agnosia can be there. And in the dorsal stream, it is the posterior parietal lobe which is mainly involved, and all these dysfunctions can be there. So we have also have a publications, and we also have seen around more than 120 cases. And once again, perinatal hypoxic episode is the most common, and followed by prematurity and structural abnormalities. So summarize, always try to avoid, its prevention is always better than cure. So avoid all these intrauterine infections, neonatal hypoxia, all that. So how do we prevent a preterm delivery? Is better care of antenatal care by preventing, taking care of the diabetes, hypertensions and all that, it will prevent. These are my references, and I would like to acknowledge Sabyasachi and Pravina Sham for helping me with the presentation. Thank you.